I'm Aman Sharma. I'm the new joint replacement surgeon at PBOA. Steve, thanks for the introduction. Absolutely giant shoes to fill, Scott and Skip. I'm gonna give it my best shot. So what I really wanted to call this talk was why I hit it from the front. My wife immediately said no. Something about professionalism, make a good impression. I said, okay, fine. So we're gonna call it the modern direct anterior total hip arthroplasty. Bleh. All right. So here's what I want you to take away from this talk, right? What are the benefits of anterior total hip and how do they compare to posterior total hips? What technology do we use in the OR to make this the most reproducible and successful surgery that exists? What does the data show? And am I just making all this stuff up, or are there people smarter than me who have studied this and understand that there are some benefits to it? And then to bring it home, we'll go over a case example of something that I think is pretty powerful. So basics, hip arthritis. When you're born, you have healthy cartilage, it's smooth, you have fluid motion, the hip moves great. Over time, one of the privileges of aging is that you wear out the cartilage, and so you get bone-on-bone arthritis, stiffness, pain. It is truly a debilitating disease. And so with the hip replacement, the goal here is to restore smooth motion. I give you a new socket, new head ball, and a stem that goes on the inside of the femur. And so the approaches do matter to some extent, right? So the two major approaches we're gonna be talking about are the anterior and posterior approaches. There are a few others, but they're not as common. The approach is just how you get to the joint. The posterior approach, classically, patients will have an incision on the side of their thigh. It cuts through the gluteus maximus muscle and then the short external rotators, which you can see in the top picture. That little line is kind of where you cut to get access to the joint. These are hip stabilizers. In the anterior approach, this is something that has become popular in the last 20 years. It is truly a muscle-sparing approach. So you go the incision in the front of the thigh, you go in between muscles, you do the bony work, and the patient leaves with all of the same muscles that they started with. And in most cases, that results in earlier return to function. And the way I do it, I preserve all the muscular attachments around the hip. The only thing I release is the capsule, which is just the covering of the hip joint. It has no muscle, and then I repair it at the end. And what I've found is that patients have less swelling, they limp less, they feel like their hip is stable quicker. And they walk, I mean, everybody walks the same day, but they feel a little bit more confident. And I think that early independence is something that we see in patients who are more likely to go home and less likely to go to rehab. And so this has been very well studied. These are two big randomized controlled studies that looked at anterior and posterior total hips. And they looked at 3 major time intervals, 6 weeks, 12 weeks, and 1 year. And what they found at the 6-week and 12-week mark, patients are just doing better. They find that their hip function is better, their gait is better, they're not relying on ambulatory aids, or they can get rid of their walker and cane quicker. But after that, at the 12-month mark, there's really no difference. Patients are walking the same. And so really the emphasis of this is that this approach allows patients to move quicker in that first 3 months. I think that's important for people who really are trying to get back to life quicker. And so what about narcotics, right? There's been a big push to limit the amount of narcotics that we give to patients because of the disaster that the pharmaceutical industry has pushed on America. And so when you have a smaller incision and you have less disruption of soft tissue and you preserve the muscles about the hip, it just makes sense that patients are gonna require less narcotics. And so with less narcotics, patients can get off it quicker, they can get back to their normal life quicker, and drive faster, get back to work quicker, especially if they're doing desk work. And this has also been extensively studied. This specific one looked at anterior, posterior, and anterolateral approaches. And it showed an 18% reduction in daily narcotic use for patients who underwent anterior total hip. That's up to 1/5 of your daily dose, which is pretty fantastic in the first couple days. As a kid, I loved technology. I used it a lot as a kid, and it only makes sense that I use it in the operating room. So the first things first, I use X-ray. X-ray allows you to size and position the implants appropriately. It lets me predict what I'm gonna do before the surgery, and when I get in the OR, it helps me verify that. Specifically, it also allows me to understand the functional position of the pelvis. When you go from sitting to standing, it lets me understand where to put the cup and where to put the stem so that there's a less chance of impingement. What that means is that less chances of the components hitting each other, which is a risk for dislocation. I also use an automatic impactor. So this is where you take a little bit of the human out, right? As a human, I can vary the amount of force that I put on the femur. And this sharp, shiny thing is basically a broach. It makes a path in the femur for the implant to sit. From the anterior approach, there are slightly higher rates of fractures. And so my thought is that if you have something that generates the same amount of force every single time, there's less likelihood that you're going to crack the femur. And that's what the study here shows too. Extremely low rates of intraoperative fractures in patients who had anterior hips using these automatic impactors. And so a machine works the same way every single time. Humans don't. So modern bearings are great. The data on them over the last 20 years is fantastic. They are at 20 years, they show almost 90 to 95% survivorship, which is really good news for young patients who are undergoing hip replacements or old patients who are afraid of getting reoperated on. And we'll get into that a little bit more later. As far as leg lengths, one of the things that happens in hip arthritis is that the joint wears out. And so patients' legs tend to get a little shorter because that bone-on-bone arthritis, they lose height. And so when you watch them walk, a lot of times they're leaning toward one side. Their hip abductors, or the muscles that help control the pelvis, they don't work as well. And so one of the things I do is I reconstruct the hip and bring the hip center back down. And there's been studies that show that using x-ray alone is not enough, that there's often some sort of distortion of the image. And so that's why I actually use x-ray plus this AI-based software that accounts for that distortion to really bring those measurements to be as precise as possible and to make the leg lengths as equal. So when you walk, it feels like your legs are even. And that's why, one of the reasons why anterior hips, they have extremely low rates of differences in leg lengths after, because you have this technology that lets you predict what you're doing in the operating and will match what the patient has at the end. And so there's also a reduced rate of dislocation. The anterior approach, when you preserve all of the capsule, all of those hip stabilizers in the back, it makes sense that the hip is functioning more like the way it was 20 years ago. There's a lower dislocation rate. And this is why I personally don't do any motion precautions. You can bend down, you can tie your shoes, you can do whatever you want. Because I'm confident that the cup's in the right spot and that your anatomy is going to allow you to walk normally. This is a big JOA study. JOA is the Journal of Arthroplasty. It's like the JAMA for joint replacement surgeons. This included 8,000 patients who underwent anterior and posterior total hips, and they found a 5 times lower dislocation rate from patients who went from the anterior approach, which is pretty remarkable. And this brings us to one of the most important parts, physical therapy, right? So because there are no precautions, the therapist can really focus on the important things, like getting patients moving quicker, focus on balance, gait training, getting patients confident so that they can get rid of their walker or cane or whatever it is, and really tailor therapy to each individual patient. And they're not worrying about spending time on making sure that they maintain motion precautions that then go away after 3 months. So you can meet patients where they are, whether it's someone who just wants to play with their grandkids or someone who wants to go hike Mount Kilimanjaro. You can start that from day one. Over the last 10 years, I've heard from many people, a hip is a hip is a hip. Just put something in, it's going to be fine. And I've always disagreed with that. I think the implants matter a lot. We'll get into this a little bit, but the modern femoral stems have been designed to reduce the rates of post-operative fractures. This implant here that you see here, it's a cementless implant. It requires your bone to grow onto it, which can take 3 months. I treat a lot of patients who have osteoporosis. Their bones are weak. And so I don't use this implant. I use a different implant that is actually cemented. It uses the process of bonding to the implant and the bone to create a stronger and more resilient bond, essentially. And the data shows that the fracture rates after are much lower when you use that kind of implant. And then as far as the polyethylene, that's fancy terms for plastic, that's that little white piece that sits on the inside of the cup. In the last 20 years, modern plastic has come around to be highly cross-linked, and the data just came out last year. This is a Mayo study that came out showing absolutely 94% survivorship at 20 years. That means 94% of patients did not need a revision or reoperation because their plastic wore out, which is pretty fantastic if you think about some of those 30 or 40-year-olds who have avascular necrosis and need a total hip. They can be confident that there's a good chance that the plastic itself isn't going to be the problem. And in that same study, 80% of patients didn't need a revision for any reason whatsoever. So that's pretty good survivorship. And then we're going to get into the weeds here for like 2 seconds. This is a modern triple tapered stem. This has come out in the last probably 10 years, and it's designed with tapers in 3 different directions. And the stem is basically the part that goes on the inside of the femur, this thing right here. And so the best way I can describe this is with a picture, right? So this is, if you look on the left, this is looking at the femoral neck, which is, imagine it's like a circle. On the left-hand side, you see the old school implants, the blade stems. You can see it just doesn't fit well. On the right-hand side, you see the modern triple taper stem. And the best way to describe it is that the geometry of these stems fit the femur better, and they allow for anatomic load transfer. So when you walk, that stem is rock solid stable. There's a collar. Let me go back for a second here. This thing, this little ledge, it's designed to give rotational stability. So when you walk, even if your bone quality isn't perfect, the stem is not going to migrate inside your femur. And that, we know, is a risk factor for post-operative fracture. And the data backs this up. This is a study done at HSS that looked at fracture rates using these modern stems 10 times lower than the older stems. So this is why I think this technology and this implant is so fantastic. All right, that's enough. I'm not going to bore you guys with any more literature. That's not the purpose of this. I'm a very visual creature. I don't believe something until I see it. So let me show you a case example. So when I was in Boston, I was credentialed as attending, and I was on call. I had a 60-year-old female, healthy, very active, unfortunately had a ground level fall. She had a left femoral neck fracture, or a hip fracture. She was indicated for a total hip replacement. And so she underwent an anterior total hip with me. These are her post-op x-rays. Again, using technology, using x-ray, I can make her hip look pretty good. Cup's in the right spot, the stem is sized well, those lines are parallel, meaning that her leg lengths radiographically are equal, and clinically they were too. So I saw her at about post-op day 17, and I saw her in the lobby. I was nervous. I wanted to just make sure she was doing okay. And I peeked out, and I saw her sitting with her knees up to her chest, and I thought, oh God, this could be good in the sense that her hip could be feeling so good that she's sitting with her knees up to her chest, or it could be horrible. She could be dislocated and be really angry with me. Luckily, these were her standing films. She was still located and everything was fine, and her incision had healed beautifully. So you can see her incision, my index finger is probably about 3.5 inches. It's a little smaller than that. It healed really nicely, no issues with that. And if you forget everything I've told you today, it's okay. This is the most important part of this slide, and this is why I think this surgery is so powerful. This is her gait at 2 weeks, 17 days after surgery. To the naked eye, I know there's a lot of therapists in the room, you're probably criticizing small things, but to the naked eye, it looks like a normal gait for the most part. And that's pretty remarkable from undergoing a major operation 17 days ago. I asked her a little bit about that, and I asked her, when did you feel confident without the walker? She used the walker for about 5 or 6 days, then she switched to a cane, and then by a weekend, she completely ditched it. I asked her about narcotic use. She used opioids for the first day, the second day, and she said it wasn't really helping. She was having a little bit of incisional pain that was fine with Tylenol. And by day 3, she was off that entirely. And so I think when you bring all this together, the thing that I want, colloquially, I think I pronounced that wrong, colloquially. Anyways, the total hip has been named the operation of the century. And when we take our knowledge of hip anatomy, our knowledge of modern implants, and use technology, I think we take that surgery to the next level. There's less reliance on pain, less reliance on opioids. There are more predictable ways to make people's legs even and reduce that rate of dislocation. And we all have the same goal. We want our patients to do well, and we want them to get back to life and doing the things that they like to do. And the key point is, with this approach, we can do that faster. I'm not very patient, so I think this is why I like it so much. And so I want to thank everybody. I'm new to this area. This is my family. Those are my 2 kids, Arya and Arjun. That's my beautiful wife, Roshni, who's here today. And that's my favorite child, Teddy, on the left. I'm from Atlanta, Georgia. People there are extremely, Southern hospitality is a real thing. And then we moved to Boston, and I got none of that. And then we moved to Scituate, and it's starting to feel more and more like home. People are friendly. I really like the people here. We are really excited to be a part of this community, and I'm honored to be able to take care of you all. So thank you so much.